Our moderator for this discussion is going to be Morgan Hania. Morgan serves as the EVP and COO of Contexture. We have Rebecca Clyde, who is the CEO of Botco.ai. We have Chris Yo, who is currently the Managing Director of Xcellerant Ventures, which focus on startups and healthcare. Give it up for our next panel.
All right, I'm switching it up on you guys. Well, welcome. Thanks for sticking with us throughout the day. We know that this is the panel you've been waiting all day for because happy hour is next. So we've got a great panel today. And it wouldn't be 2023 in a healthcare conference if we didn't talk about AI and analytics. And I know that we've already got a bunch of questions rolling in the Whova app, so keep them coming, and we'll make sure to get to them at the end of our discussion. So I'm going to kick us off because I actually had to do my own research onto what this panel was before I came up here with you guys. So let's just do some level setting. I want the two of you to define, from your perspective and knowing our crowd today, what is analytics and generative AI?
Well, I'll take generative AI because that's what we focus on. So the concept of AI has been around for quite a while, actually since the 70s. There's been many different AI modalities, but what really changed things were the transformer technologies that came out just in the last couple of years. The T and GPT, that's what it is. And what it allows to do is to create essentially a predictive system that allows you to project what the next word or the next piece of data might be for a particular either conversation or image creation. It's the first time we've ever been able to use AI not just to model things, but to actually create or generate new content based on existing content. So hence the word generative. It's kind of taking things to the next level. Do you want to take the analytics?
Okay, I'll try. Chris Yu, as mentioned, I'm part of a venture capital firm, so we see a lot of technologies. But at the end of the day, AI and everything that we do with data is data analytics, right? Whether it's you sitting at your computer staring at a spreadsheet or an AI-based system revealing insights. And so I think the term data analytics went from something, in the beginning of using pencils and actually erasing things on pieces of paper to compute to now things that are operating autonomously on their own 24/7 and coming up with insights as easily as we speak and as easily as we ourselves generate information.
Thanks. So now that our audience is all experts in AI and analytics, obviously this is a topic that has dominated the airwaves now for quite some time. But where do we even start? If we're sitting in the audience or we're going back to our offices tomorrow and we're like, I hear about AI, I think about AI, there's obviously limitless applications. But where do we start? And have you seen any low-hanging fruit where you've seen some immediate success?
Sure. That's what we do at Botco.ai every day. So we have nearly 30 healthcare providers that are using Botco.ai today to facilitate patient engagement primarily. And so the way that our product is being used with those provider groups is to basically support and augment your front desk and call center staff. So anytime somebody is making an inquiry about their health care, they're getting an instant response. And that we can also facilitate workflow automation, such as appointment requests, eligibility, rescheduling, any of those things that are burdening your phone banks, we can handle those using generative AI. And so how does it work exactly? It is a model that is trained specifically to your organization's own data. So we're not talking about using OpenAI or ChatGPT type of content. This is your own provider information, including the procedural manuals or the content that you have as training content within your organization. And then we facilitate a virtual agent that is ingesting that data, has access to it dynamically, and can answer questions about anything that's in that data set. that has been authorized to share with that individual. So if somebody wants to call and find out if their lab results are ready, they can just chat, get an instant answer, and it doesn't matter what time of day or night that might be. That's low-hanging fruit in the sense that it enables you to provide better access to care, because now you're not reliant on that friction of the phone and the call center as being kind of like a barrier to entry or barrier to access. That's one of the many ways. How about you, Chris? What else are you seeing?
Yeah, I mean, we think Botco is one of those solutions that is, that everyone can use, right? So whether you're a provider or you're a patient, anyone in the healthcare continuum can use it. There is the issue of course, accessibility, right? Can everybody use a computer or a hand phone? I think the interesting part is hand phones are ubiquitous now, smartphones. So most people know how to access information using their phones. So the question becomes, what is it that we're trying to achieve, right? What is society trying to achieve with all this very powerful, very exciting new technology like Botco? And I think when I thought about this question, it's like, where do we get started? We're now able to have communication and conversations with AI, with a non-human. Do we have more trust with that solution than we do with another human? I mean, I think that's really the question, is healthcare is all about trust. And so what I've always admired about Rebecca and Botco is that's been a guiding principle in their solutions, is to establish trust between the patient asking questions at 3 a.m, and the system, which may give that patient a better feeling about, I trust healthcare. I trust that my needs will be fulfilled. So I think that's really low-hanging fruit. Focus on trust in the system, bring back that element of both sides of the table, healthcare worker and consumer of healthcare, understanding that we can trust each other, we can communicate.
And I can say, and also identify those areas as the biggest pain point, right? From somebody who's run healthcare organizations, I certainly know I don't think that anybody has fully figured out the phone system and the call center model. And so that obviously is an area ripe for the picking. So as you talk about what you're doing in this space, and you just gave a couple of great examples, what are some of the things that you're doing to measure the impact of these efforts or measure the impact of this technology?
So we have a number of customers that have studied everything from improving what they call, the intake velocity. So from the time that somebody requires care or they get referred into care, how long does it take for them to actually get into care? And right now, unfortunately, we know that a lot of referrals go, I would say, it's like more than 50% of referrals sometimes go unattended. They don't get fulfilled. And oftentimes that's because there might be phone tag in the way, appointment scheduling is difficult, they lose track of the information, there's a bunch of different reasons. And so what we've seen is that we've been able to essentially, for providers that are using our solution, reduce that to 0. And this is even happening with referrals that are coming from, public safety, Department of Corrections into behavioral health, for example. Those are essentially now bypassing all of the friction that used to be there, and we're getting people into treatment and into care much faster. So we look at that, and then we also have organizations that are just measuring outcomes. Is the fact that they got care when they needed it also resulting in a better outcome at the end, right? Are we preventing future problems from happening because we've essentially streamlined the intake process and the ability for somebody to get access as soon as possible?
Yeah, and I think that's the right way to look at this. Is there are certain metrics that any healthcare system is going to want to know whenever they implement a new technology, and Rebecca just mentioned some of those. I think there are also some of the soft metrics that are important that many of you have talked about already in previous sessions. We, for example, at Xcellerant just invested in a company called True Light Health. And the reason is the way that they're measuring success is, can we bend the trajectory of this inequality of access to care and the outcomes that occur because of that, right? So by incorporating little nudges and ways to help physicians recognize disparities in their patients and then pay attention to those, you're able to now create systems that help us get closer to parity, right? So those are more of the metrics that are longer term that are probably not as easy to measure as how much more efficient were my workers, how many more patients did we see. I think we need to pay attention to those because, again, coming back to the theme of trust, if the patients don't feel like they're getting the same care as someone else, it's a broken system. So I would encourage us to think of metrics that way. The other thing I'll mention is there's measurement of risk, right? So for any healthcare provider and for any patient trying to decide between a procedure or not, there's this element of am I calculating risk appropriately? And I think more of our systems, especially with AI, new technology coming in, we have to start to figure out how do we measure the introduction of risk? Are we reducing risk or are we increasing risk? Does a patient feel more certain or uncertain about the kind of care that we're providing to them?
I was working with a company a number of years ago that did just that. They would take, the medical record of an individual and then provide education for the patient about, like, here are the risks because of your certain conditions of, why you may or may not want this particular procedure. And back, that was probably 15 years ago. I'm much older than I look, but the informing the patient to try to make sure that they are confident in the decision that they're making, maybe at the request or the direction of their healthcare provider, I think goes a long way. And even, the healing process and the recovery process, if you feel confident that you've made the right decision and you followed the right direction. So that's a fascinating use case. So sticking with the overall theme of the conference, and of course the name of this panel, the future of analytics and AI, are there specific use cases that you really see ripe for addressing? I mean, we talked about the call center automation. We talked about lowering the risk or inserting information about the risk. What are some other areas that Contexture or audience members should be thinking about that is like a practical application for these technologies?
Well, one of the things we did that's more of an SDOH initiative that I'm really excited about here in the state of Arizona, in partnership with Valleywise and 211, we essentially enabled the first chatbot for social determinant of health issues. And so this is a statewide initiative where based on where you are, your zip code, you can get access and identify what is the hyper-local resource to you that can help you with food, clothing, diapers, transportation, any number of essential services. So that if you are homebound for whatever reason, you can't get access to food, you can request delivery right there from your phone. And this was a major partnership with a lot of community organizations, some of you which are in this room, made possible through that type of collaboration. And somebody had said earlier that, our home is essentially healthcare, and it's true. If we don't have our home, if we don't have food, then we're definitely going to end up in the emergency room. So these are super important initiatives, and I love that Arizona is really the first state to implement this capability, and I think we're getting noticed from a lot of other states as something that we're doing that's very unique here. So that's something that I'm particularly proud of and excited to see happen here in Arizona.
And speaking of Arizona, I mean, Botco, True Light Health I just mentioned. We have another company called AdvaNow that encourages physicians to kind of allow a system to input data about a patient as the patient is kind of interacting with the physician, a lot more automated than, say a physician trying to scribe while they're listening to the patient, while they're trying to enter data into the EMR. So I think there are clear efficiency things that we can do today to make healthcare a little less painful. I like to ask people this question. I like to ask, when was the last time you said, oh gosh, I can't wait to go see my doctor? Right? It's like saying, oh gosh, I want to go see my dentist, right? It's painful. Healthcare service is a painful process. If we can set up systems in a state like Arizona where we can pay attention to what's the whole spectrum from how is the condition at home to the economic circumstances of the patient to systems that start to get to know the patient better. I mean, why is it that Netflix can recommend the right movie to me and yet I have distinct trouble trying to find a specialist to handle a healthcare need, right? And those are fixable. Another one of our companies that we've invested in called Porter Cares is trying to build the Amazon-like platform for healthcare. Everything from care delivery to DME to scheduling, et cetera. And I think they're all lots of little pockets. Is it Ray Kurzweil who said, the future's here, but it's in little pockets everywhere, so you can't really recognize that the future's here? I think that's true with healthcare. Is soon the future will be where these things are much more interactive with us, like Botco, where it's actually answering us in a way that we find pleasing, and then that trust component comes in where we start to trust the system that's in front of us. And I think the really cool part would be where I think the future is, all of these devices, RPM, remote patient monitoring, patient-reported outcomes, that data is cleansed and made useful, just as useful as data coming out of a hospital system. I think that's coming.
Yeah. I was going to add one more thing, and this is really important here in Arizona, where nearly 40% of our households speak a language other than English in the home. This is an ongoing trend in the United States. It's not just Arizona. I was just in Houston. In Houston, 50% of households speak a language other than English in their home, which means when those families arrive at our doorsteps as healthcare providers, they're going to need language services in other languages. And that's another amazing opportunity for AI. And that's one of the top requested things that I get is, hey, how many languages does your product support? I just got a request for Navajo, and I was like, absolutely, we need to do that. So that's also another piece of low-hanging fruit that you can enable within the conversational interaction and making the content of healthcare more accessible. So, there's clinical language, what I call, which even, having a master's degree, I don't understand half of what my doctors write in the notes, right? Because I didn't go to medical school. So being able to explain that to somebody in a different language and in a way that's accessible to them and understandable, and now they can take home those recommendations, and their family can support them in fulfilling adherence to those requirements or orders. That's also super important, and that's an area where AI can really, really help and bridge that gap between what's happening at the clinic and then what ends up happening at home.
Yeah, that one is absolutely an applicable one. I used to serve on the board of a federally qualified health center in Denver, and a lot of people may not know this, but Aurora is a major refugee center for the entire United States. And in the Aurora public school system, there are over 268 languages spoken. And the FQ that I was on the board for, they were spending almost $50,000 a month on clinical translation services just to be able to pick up the phone and have a person on the other end of the line that could speak one of those 265 languages. So that's a great use case. I'm going to go off script. You guys seem like you're okay, flying off the cuff. So let's flip that question upside down and say, as an investor or experts in this field, what are the things that you kind of look through a lens of skepticism on we know that the sky is the limit in this space, but what are we not quite ready for, or what's the bridge too far when we talk about the application of these technologies right now? See, I told you I was going to throw you a loop.
For us, we're really not moving into the delivery of care itself. So for example, our product will facilitate everything you need to get access to a treatment or a service, but we're not going to deliver the treatment or the service. We're leaving that to the MDs, to the clinicians, to the people who are properly trained. And I think for us, that's kind of like the handoff, right? We want it to be smooth and we want it to be as effective as possible, but we're not moving into that space because I still think it's a very almost sacred space, and our goal is to create a great patient experience around that so that the clinician and the patient can have the best possible experience together, but not necessarily trying to replace the clinician. That's an area where I think right now we still need to wait a little bit to see what happens.
I had the privilege of getting a little more time here to think about this one, right? But I think when people say, "Oh, we're going to get rid of the doctor, we're going to get rid of the nurse, things are going to be all algorithmically driven, and data-driven decisions are going to be so accurate that we won't need, a human who's more prone to error," right? Any of you have a like Tesla, self-driving car type of thing? Okay, so I have a Tesla, and I can tell you when they say it's aware of what's going on the road, and you can trust it. It's like there are times again when you really need to establish a human-to-human connection, right? And that will never go away. And I think we will get better and better at personalizing care, right? All this data will drive towards systems that are better tailored to us. We have systems that can actually converse with us where information's collected that's useful in a healthcare decision instead of press 1 to go here, press 2 to go there, right? So I think the fallacy is that we can get rid of the human component. I don't think that'll ever happen because healthcare is a human bond between one person and another and a system. And the other thing I will note is there's a lot of belief that there are all these subtle signals in a lot of data that are going to be able to predict things later on, right? And I just read an article about, I think maybe it's Aura, the ring that kind of measures things. Now they've incorporated a chat function in their portal, I think, and you can ask it questions like, "Am I sick?" Well, most people just do this, right? And go, "Yeah, I'm sick," or "I'm coughing, I'm sick," right? I don't need a ring and a service and a system to tell me I'm sick. I am sick, right? So I think those are kind of like basic things that we're not going to get rid of with AI.
Yeah, my wife would tell you that it's very easy to tell when I'm sick. I'm a huge man baby when I'm under the weather. So let's talk a little bit about what do you see in the industry right now, or maybe across industries, as some of the biggest barriers to really adopting or implementing these technologies?
Well, I was just going to say, I think in the healthcare industry, I'm actually seeing quite a bit of enthusiasm as opposed to hesitation. And I think this is driven because of the pain point that everybody is experiencing. Somebody here told me, I won't reveal who, that the typical caller into their health system gets transferred 15 times. I've called just about every FQ in town, and the typical hold time is 30 to 60 minutes. These are not good experiences. And they know that. They know that they need to fix these problems. And so there has been very warm reception to finding alternatives that make access to care better. I think what is sometimes difficult is exactly what we're talking about here: interoperability of the data, ensuring privacy and security along the way, making sure that we're not compromising anybody's information. Those things must be adhered to. And so I think sometimes when the brakes get put on a project, it's just to make sure that all those things are in place. And I think those are good kind of evaluations that need to take place. Like information security has to be there. And I think all of us in this room probably have a very strong commitment to that idea. So it's not that there's hesitation, but it's like, let's make sure that as we adopt these solutions, we're not compromising the data, or we're not creating new problems that are only going to make something worse down the road.
And I think coming back to the idea that humans are important and trust is important, when medical decisions are made, the more data that's available, that's good data, is often seen as better. But when it becomes overwhelming and it actually introduces more uncertainty, that's probably not a good thing. It's probably why we have these, 30 to 60-minute wait lines. I think the risk and mitigating risk is important, right? So the 17 years that it takes for some medical technologies to be adopted, it didn't take that long for a cell phone, right, to be used by everybody in a hospital, right? But we still won't text medical data unless you're using some sort of system that's very secure. So I think there's a risk component that we have to think about as a society. Do we feel like it's important to have rules and regulations around areas that we want to see faster innovation, which brings along potential failures? And I think we probably need to think a little bit more about prioritization. And if we could come up with solutions that would solve some of the major problems that we have around healthcare, and yet we have to kind of lower some of the barriers to those adoptions around rules and regulations, do we do that, right? There's a great book out right now, a biography of Elon Musk, and you'll see in his algorithm that he uses, the number one thing that he does is he challenges rules and authority, right? Can't really do that in healthcare. You may be able to do that in technology that he's involved in, but we have to think about that because it's always going to be part of our industry.
For sure. And a couple of things that came to mind while you were talking just then, as we heard from a panel earlier, the negative impact of becoming reliant on these technologies. So we heard a story about how a clinic's internet goes down and the EMR comes offline, and I've got doctors who don't know how to pick up a pencil and do an old old style past medical history, right? Because the stuff is not at my fingertips. So I think that that's an area that we need to be concerned with, or always have an eye towards, maybe not as concerned with. The other thing that I'm constantly thinking about in this space is, I think a lot of times people immediately go to the user experience, or how can we feel the impact of AI or analytics. And in our space, we deal with huge amounts of data. And one of the things that is a constant challenge for us is how do you bring that data together, translate it in a way that everything means what it's supposed to mean. Even in medical records today, you have so much space in there where it's free text, or I use the example of my kids are biracial, and so when I go and check them in somewhere, I check the other box on the race category because my kids don't fit perfectly into the 5 boxes that are on that check-in sheet, right? And so we spend a tremendous amount of time and effort and resources trying to make sure that when you open up our portal or you get that information back into your EMR, that what was put in at the source is exactly what it should be when it comes out the other side. And I think that that's a huge space. There's so many applications for AI and analytics kind of behind the scenes of things that create a lot of challenges right now. So let me get back to my paper here. So how do we make sure that this technology and these services are actually adding value? How do we make sure that we aren't, further potentially isolating different populations, that we're thinking about the ethical implications of the technology, that we've heard from a number of panels today about just the enormous challenges of social determinants of health and homelessness and food insecurity. How can we make sure that as we're adopting these new technologies that we're not actually exacerbating those problems but making a positive impact?
I mean, I have to credit a couple of different sources of influence in my own journey that ensured this. So number one, I was actually raised outside of the United States. I was born in Central America in a third world country. I grew up not in this world where we exist now. And so I understand the experience of probably people who are newcomers or immigrants differently than maybe somebody who was born here. I also appreciate a couple of investors that I've had along the way who wanted to ensure that there was an impact component to the technology. And in fact, one of them said, I want to make sure that a certain percentage of your customers are serving underserved communities, and that's actually going to be a requirement for us in order to invest in you. And so when those kinds of guidelines are put in place, the fact that first they invested in a Latina, born outside of the United States, and also wanted to make sure that my product was being built with the underserved in mind, I think that's where it all begins, is at the capital allocation and at the company formation stage where those seeds are planted. Because then we create companies that have the DNA for a different perspective. And it's not, you don't have to convince me to go do those things. It's already part of who we are. Like, we provided multilingual chat services from day zero. It was a must-have inside the product because I was like, we live in Arizona, todos hablamos español, like we have to have it, right? So those kinds of things will only happen if capital allocators are thinking about investing in a way that is going to represent the population and the world that we want to see down the road.
Yeah, and to that point, you know, for Xcellerant Ventures, it's been important to us to look at founders who are not your typical white male, 30-year-old, you know, coming out of Silicon Valley. 40% of our investments are women CEOs, right? And I think the statistic is like 2% of all of the venture capital money goes into that kind of standardized founder type. I think it boils down to two things. One is, as you invest in founders as an investor who represent diverse viewpoints and come from different backgrounds, they bring a lot of opportunity for new markets, right? And so Rebecca mentioning, you know, where she came from, there are vast untapped markets out there for healthcare in particular if we simply open the aperture a bit more towards more cultures and serving the needs that, you know, are specific to those cultures. The second part is education. So these AI systems, right now we're at the, you know, kind of the, wow, generative AI, that's great. It can converse with me and it can generate, you know, interesting information. But what we really want to get to are these rapid learning systems where the AI is learning. It's not just saying, okay, I found a pattern, let's make that stronger and stronger through neural nets. It's actually, there are edge cases that are important for a system to know about and to not just follow the strongest neural connection, right? And I think that's a learning system. It's important for us as folks in the industry to also educate. So I enjoy teaching. I think every single person in healthcare should be involved in teaching. You know, go to your local university or community college and try and add value to some of the younger folks who are going to become healthcare workers. I think those are two elements that are important.
I love that. I absolutely love that. So I know that Emily told us that we've got lots of questions for our panel. So I'm going to ask one more, and then we will move into questions. And Jeff's also flagging me over there. So Doctor, you almost stole my thunder. So we know it takes 17 years on average to adopt new technology in healthcare. Is AI going to be another one of those things where it's the buzzword of the year and then it's, you know, a decade out before we actually see the practical application? Or for the folks that are in the room today, is this real and upon us, and are we going to start seeing this thing take off, or are we back into the 17-year cycle?
Yeah, I think we won't even know that it's there. That's the issue. It's like we see very high-profile things like radiology, right, where it's like, hey, you're going to replace a radiologist. You're never going to replace a radiologist. You're just going to make them better at what they do, right? And we're going to make the system more accurate. It's these underlying systems. Many hospital systems now have RPA. You know, they have robotic process automation where, you know, there are things that are being done behind the scenes that you already see the technology seeping in. The question is, have we designed it so that when errors occur, we know how to identify them, right? Are we in the land of explainable AI? I think if there's any danger, it's happening now. If there's any danger of it slowing down, it'll be because of the risk, right? That we can't explain a judgment, we can't explain a decision. And I think those are Those are things that we need to consider as we design systems.
I mean, I would say COVID was a major accelerant. It was like those 17 years were lived in 1 year. It feels like. And hats off to all of you who are at the front lines of much of that, and probably are still trying to recover from, 3 years of just onslaught. I would say the accelerant for us, at least, was definitely COVID. We were able to train our initial models on call center transcripts that were basically, given to us by one particular, a couple of different provider groups that basically said, look, we cannot sustain the level of volume that we're getting into our call center. We just cannot. So we have to get some things trained. How much data do you need to train a model, and how quickly can you do it? And so we did this within a couple of months. We were able to stand up our first AI service for a behavioral health provider, primarily focused on delivering drug and alcohol treatment, because as many of you know, that was the co-occurring disorder with COVID. And suicide rates were going up. There were major overdose issues happening, and they had to get in front of that, because when somebody has that moment of courage and decides to call for help, you better be there to help them, because they may not have that moment again. And so that sense of urgency really propelled a lot of these providers, and hats off to them for being willing to just go there and work with startups like us to put these solutions in place so that nobody, whether it was 3 a.m. or a Sunday or any time of the day, if they reached out because they needed help, they were able to get access immediately. And so we're not seeing a 17-year adoption for some of these things because of the urgency that was required to act.
For sure. And, again, as a healthcare administrator, the problems that we have not been able to solve, right, for years and years and years, decades, to be able to apply a technology to solve those relatively quickly, I think that'll also create urgency as well. All right, so great discussion. I know that we've got lots of questions in the chat, so I'm going to call Emily up here. We got the warning that it's hard to hear the questions being asked, so we'll do our best. But Emily, if you'll come up here and start peppering us with audience questions. No softballs. We want them all high and inside.
I feel like Jeopardy or something.
So you guys have done an incredible job. You've answered so many questions already. So the first one, and these ones are neck and neck. What do you think about natural language AI in the clinic setting, i.e. Alexa, what are the A1Cs for this patient for the past year? Please schedule labs for this patient.
I mean, who takes the risk if something's missed in that case, right? So where does the liability lie? Can you sue ChatGPT if it gets it wrong? I mean, I think that's going to determine whether that is a service that can be used. It's not whether it's more accurate or it's faster or it's better. It's going to simply be, there's a liability risk there with using a system. So can we establish that use of that system, still puts the burden on the healthcare provider, the human? In that case, if the human is making judgment calls based on better information, that's great, right? It's really up to the healthcare worker. So I think that is going to boil down to, liability.
Right. Did you want to answer that too?
I'm good.
All right. There's like 18 more. All right. And you touched on this already, but what ethical considerations go into training AI, particularly for decision making? What is the AI examined for bias, either from the data it learns from or from its creators?
Yeah, and I think one of the key things that we always talk about with customers is ensuring data accuracy and cleanliness and appropriateness prior to embarking on a project. So, and data completion, right? Sometimes we'll see missing examples. So, for example, going back to the call center transcripts that we mentioned, it's very common for us to ingest all that data. We, train the model. We start testing it, and we notice, like, wait, you guys missed like a whole category. And usually it's because we basically have a generative model that will test questions, sample questions. So we hit it with like millions of variations of all the ways a person might ask a particular question. And we'll notice that maybe there's a whole missing type of data set in there. So they forgot to include maybe an entire service line in the data set, or they forgot to include something else. And so I think it's very important for providers to pay attention to the data that's going into these systems, the accuracy and completion of the data, to make sure that it's actually representative of the population they're serving. Because if it's not, then you're going to be back, reinforcing existing biases and missing data in healthcare.
So there's about 3 questions that have the same theme, and I don't know if this is a Morgan question, but do you think it's possible to integrate these models or methods into existing EMRs? I ask because most providers do not want to log into another system when providing care.
Yeah, so I've been in the IT space nearly my whole career, both when I was in administration and in this current role. And the question that you have to be really careful asking, and I can't see my CIO, so I'm safe at this point, but is it possible? Yes, it's possible. Is it doable, and can we do it today? That answer many times is kind of, yes, we could do it, but here are all of the reasons why we can't. I think to go back to one of the earlier questions, as we think about the future, and being able to ask Alexa, like, what was the last A1C test value? A critical component of that capability is going to be having this data ecosystem where you know that the gaps in the source information are as small as they possibly can, so that you minimize the risk of not knowing, oh, well, I can look in this EMR and I can see that, yes, your A1C was 3 years ago, but what it doesn't take into account is that for the last 3 years, I've changed my insurance coverage every year, which has forced me to change my health system, which means that my data is actually living somewhere else, right? That's a bigger risk of missing something that actually did happen. So I think as we think about the possibility, I think that in states like Arizona, Colorado, others across the country where we really do have that strong foundational data, health data ecosystem, incorporating advanced directives, incorporating social determinants of health, that we're gonna have so much more water under the bridge in terms of the critical infrastructure that has to be in place to enable those types of things as we continue to develop this technology and put it into application. I totally understand, the reality of working inside an EMR, having to go and pull information in. If you were here this morning, you heard Melissa talk about the roadmap of our one platform integration, and that's going to be foundational. It really is, because today, for some health systems in Colorado, we're able to, trigger queries on the on the HIE so that we can take all the data that's on that patient within the HIE and push it right back into the EMR. And then a little light pops up and says, hey, you might want to come look over here because something that doesn't live in your system just showed up. That's inching us closer, but I certainly think that, to the pain points and to the things that are ripe for the picking, there's lots of examples whether it's dictation to text, or the constant use of free text fields where we can start to capture that data and make it actually useful, so that our providers aren't spending 30 minutes just reviewing the note because I've got 7 minutes in front of the patient. So is it possible? If you ask a technologist, it's almost always possible. Is it possible today? Yes. But are we doing it today? Are we ready for that? Probably not. Do I think we'll get there? 100%.
I mean, we do in every case. It's always a requirement.
Stand corrected.
So this is the top rated question right now, and I know you just talked about it, but when? Yes, so how long will it take to get to the point where AI technologies will be run against the datas and HIEs presenting findings and analysis to providers? So yes, it's possible, but
When?
when? We can move on.
Soon.
Soon, yes. And I can't see my CIO, so I'm safe in saying, like, is it on the roadmap today? No. Are we absolutely keeping an eye on how we can continue to adopt these new technologies and simplify the use and increase the user experience? And then, at the end of the day, I think everybody is in healthcare for the right reasons and for similar reasons. We got into this industry and our jobs because we care about people and we want to make people better and we want to improve lives. And I think when we, to Rebecca's point about COVID as an accelerator, when we see the impact, the improved outcome of what you can get for your patients and your staff and that experience of interacting with your organization, I think that's going to be a big driver in how fast we do these things. Because if we can show, look, you apply this technology and you get this different outcome, that's what's going to make a big difference. And it can make a big difference for your business, it can make a big difference for your patients, it can make a big difference for your staff. And let's face it, we talked about new grads coming out of medical school, and they've always been, they're technology natives. That generation and future generations, they are going to want to go work for companies who can give them the best experience, can provide them the best technology, that make them feel good about why they chose going into healthcare. And I think that there's all sorts of factors that are going to drive how fast we actually do this.
Yeah, and I'll just add to that real quick that healthcare is, we all know, being consumerized, right? It's becoming consumer ingested type of service. The more we are proactive about our health because we know that we can do something about it ourselves before we interact with the healthcare system, I think that pushes the healthcare system to be that much better, right? So I think we have the advantage of having technologies today that do so many things for us, especially enabled by AI. Healthcare will come along. It will have to, as we get more and more sophisticated about what we want and what we expect.
And I would just tack on one more thing. I think, 5 years ago, telemedicine was absolutely a thing. But it was a thing that kind of trickled into the healthcare ecosystem, right? When COVID hit and market forces and the reality of the situation forced people to pivot, you saw telemedicine go through the roof. And so a month ago when I had COVID and I'm, big man baby in my house and my wife has given me all sorts of grief about go to the doctor, and I call them up and they say, nope, we do those via telemedicine. I mean, that's where you see the rapid adoption.
Well, and I think the other force that's kind of pushing that is, we've talked about the aging of America, and the preference for seniors is really going to be to stay home along those lines. I don't think that we can possibly expect for seniors at the rate that we have now, the largest living population on the planet, baby boomers, to always want to leave their house for every single healthcare appointment. They're going to want to have those healthcare appointments in the home. So we're going to be driving remote patient monitoring, driving hospital in the home technology, and it'll create more interception points for this it's going to just be yet another accelerant in getting the adoption curve going.
Thank you so much. We really appreciate your expertise and feedback.
Thank you.
Thank you.